dealing with the complicated proliferative diabetic retinopathy cases is really challenging to any vitreoretinal surgeon. At first, we have to define what do you mean by severe proliferative diabetic retinopathy. And these eyes with no or limited PVD, combined traction rheumatogenic retinal detachment, extensive fibrovascular proliferation, extending beyond the equator and sometimes reaching the periphery because there is no PVD, active neovascularization with no or inadequate PRP, and chronic traction retinal detachment with retinal thinning and ischemia. What are the surgical objectives in proliferative diabetic retinopathy? Elimination of traction and elimination of ischemia. And this is achieved through removal of media opacities, removal of the two scaffolds that we talked about in the previous presentation, removal of all fibrovascular tissue, retinal reattachment, adequate PRP, and hemostasis. This leads to restoration of the vision, and this helps to, the final aim is to achieve a clean, attached, stable retina and long-term anatomical and functional results. Surgical technique in proliferative diabetic retinopathy may be segmentation, delamination, peeling, or a combination of all of these techniques. These techniques may be done unimanual or bimanual using scissors or probes, but no single technique is perfect for all cases. You have to be creative, patient, and committed. Surgical approach is dedicated by the pathoanatomy. The surgical approach may be from inside to the outside, that is the centrifugal, or from outside to the inside, that is the centripetal technique. Small gauge probes really added much to the technique of dealing with these complicated cases. With a small gauge, you can define planes, mechanical elevation of tissues. It can act as the vacuum can act as forceps, flute, or back flush needle. So tissue manipulation or peeling, traction to expose epicenters, breaking of epicenters, and evert tissues to be excised away from the retina, the so-called fold back technique. And cutting, you can use the cutter as a vertical or a horizontal scissors, so you can perform cutting with the front or the sides. That is the so-called conformal technique. Reduced traction on the retina and segmentation and delamination all can be done with the use of the small gauge vitrectomy probe. What about injecting the preoperative injection of anti-VEGF? They reduce the vascularity and reduce the intraoperative bleeding, but do not abolish the bleeding and may loosen the epicenters. But be cautious in these cases with encircling traction over the macular area, because injection of anti-VEGF may lead to the contraction and may induce bleeding, creation of retinal breaks, and more extensive traction retinal detachment. Let's have a look on this patient. This is the technique how we use the 23 gauge or the 25 gauge in dealing with fibrovascular tissue, covering and distorting the posterior pole, and the probe is used to find the cleavage plane and then elevate the fibrovascular tissue. And once the tissue is elevated away from the retina, you start to activate cutting. And you go around the epicenters, and once the epicenter is free, you can eat or remove the attachment to the epicenters, and this is continued from the periphery to the center, or you can detach the tissue on the optic disc and start this technique from the center to the periphery until the whole fibrovascular tissue is removed using only the vitrectomy probe. And this is the post-operative picture. The retina is stable and no proliferation, and the retina is left completely clean. This is a case of severe traction retinal detachment. Also, the probe is used at the beginning in order to elevate the planes, discover the cleavage planes, and removing the fibrovascular tissue, going in between the retinal folds, trying to elevate the fibrovascular tissue away from the retina, and sometimes in this elevation, you can sever the epicenters, and then you activate the cutting, trying to isolate the epicenters, and then you can eat the epicenters. Sometimes you have to do this in several quadrants in order to achieve the release of the tangential traction over the surface of the retina. But the forceps is used. Then I couldn't remove the fibrovascular tissue from the periphery to the center, so I decided to work from the center to the periphery. So the forceps is used in order to detach the stalk from the surface of the optic disc, and at the same time testing the adhesion of the fibrovascular tissue to the underlying retina. Sometimes by doing this, the adhesions is loose, and you can peel a lot of membranes, and then you can perform the segmentation, and then I'm testing, and you can see the sheen of the attached posterior hyaloid, because here there is no PVD in all these areas, and you have to work slowly, patiently, in order not to create retinal breaks. Of course, no one is immune from creating retinal breaks, but the breaks should be as few as possible, and working to the periphery, from the center to the periphery. And the more you work to the periphery, the more the membranes become thinner. This is how to fold back the tissue away from the retina and to be cut by the probe. And then at last I found that these tissues cannot be managed alone with the probe alone, so I resort to the bimanual technique with forceps and scissors, and doing segmentation and delamination, working with the scissors closed, using it as a spatula, and when it is open to cut, it cuts the epicenters, and slowly the underlying retina become free from the traction exerted by the overlying fibrovascular tissue. This is the same. Again, you try first the delamination using the probe and passing from the center to the periphery, working from different directions. Sometimes when you cannot find your way or cleavage plane in one direction, you move to another part, and in this way, this may help in facilitating removal of the whole fibrovascular tissue attached to the underlying retina. Again, this is a case of severe traction retinal detachment and vitreous hemorrhage. You work from here you cut the connection between the fibrovascular tissue and the peripheral part of the retina. Here, again, the fold back technique, trying to remove the fibrovascular tissue. And usually there is a membrane, a transparent membrane, connecting the peripheral part of the fibrovascular tissue to the peripheral part of the retina. Here you cannot go under the retina, so you have to find another way. And the only way is, again, to work from the center to the periphery, detaching the fibrovascular tissue from the disc in order to find the proper cleavage plane. So when you fail to find the cleavage plane in the periphery, go ahead and detach it from the attachment to the optic disc. Again, this is the case of severe traction retinal detachment. The vitrectomy probe is used to divide the adhesions The macula is detached as a tabletop traction from different parts at the arcades, working from the center to the periphery and dividing the tissues in order to relieve the tangential traction until and this is the peripheral faint membrane. This is the membrane. And without discovering this membrane, you will not be able to find the cleavage plane from the periphery. So you have to find this thin membrane connecting the edge of the white fibrous tissue to the periphery. And this is continued until the whole fibrovascular tissue is removed. This is the case of combined traction rhegmatogenous retinal detachment, and I thought at first I need to work manually because the retina is mobile, but the mobility of the retina is not dangerous. So I decided to complete the work with the 23 gauge vitrectomy probe. And you have to use, in these cases, you have to use the minimal suction and the high cutting rate. Here going to discover here, the probe is used as a spatula, and as the probe is withdrawn, it is used to cut. And this is another technique that can be used with the vitrectomy probe. So when we are obliged to use the bimanual surgery, these are cases of severe traction rhegmatogenous retinal detachment, large areas of fibrovascular proliferation, strongly adherent to the underlying retina with closely placed epicenters, and chronic retinal detachment with ischemic thinned retina. Here I tried first the technique, the probe, but shortly I realized that the underlying retina is too mobile and it is difficult to deal with the fibrovascular tissue. So the only way was to use the scissors and forceps. And you have to adjust the chandelier light so as there will be no reflection and no shadow. And you have to see the epicenters properly and clearly before cutting the epicenter. Sometimes you have to push the retina away to discover or to reveal the epicenters, and then so it is a combination of cutting, pushing the retina and traction with the other instruments until the whole retina is relieved. A case of severe tractional retinal detachment, the probe is used to try to detach the fibrovascular tissue, but it was difficult. And so I decided just to cut the attachment in order to allow injection of PFCL in order to attach the posterior retina to provide some stability of the highly mobile retina. Now I could detach the stalk from the disc. And try to peel the tissues to the periphery, but this was difficult. So I injected PFCL to stabilize the posterior retina, and the bimanual technique, here the PFCL is injected to stabilize the posterior retina, and then the probe is used to cut the transvitreal tissues. But after some time, you have to use both hands. Here again, the forceps and the scissors were used to achieve the task and complete the removal of the fibrovascular tissue. And this is at the time of silicone oil removal. So ILM peeling selective or imperative in these cases? I believe that it is imperative. This is the case of old case. It was operated long time ago. The ILM was not removed, and the result was recurrence of epimacular proliferation. And this is the case of severe traction retina detachment. And here the retina, you cannot unfold retina without doing ILM peeling. And this is the case of macular hole developing 5 years after doing vitrectomy. And if I would remove the ILM, it would have not occurred. And this is the post-operative picture. So this is the pre and the post-operative of pictures. Anti-VEGF in eyes with active neovascularization, complete removal of the posterior hyaloid, leaving the retina completely clean, routine ILM peeling over the largest area possible, internal cleaning of the sclerotomies, adequate intraoperative hemostasis, adequate PRP to the aura, and silicone oil in high-risk cases. Thank you for your attention.